Have you changed the PowerPoint at all? Have you changed the PowerPoint at all? Yeah.
You just have to turn it on. I didn't turn it on.
It's much better live. You guys made a good choice. Yeah. Although Katie, you made a good choice too. I'm glad you're here.
Driving in from Paisley with Seek.
It's a little eye that stares at us.
Can you guys hear me?
Katie, can you hear us? Oh, is my mic off? My mic might be off. Oh no, Katie's mic is off. Yeah, so we have one person.
Can you hear me?
Yep, we can hear you. Perfect.
Awesome.
Just so you can keep muting yourself, Katie, just let me know if, and I've got the PowerPoint running on my computer, and then it's also gonna be live, so just let me know if there's anything that you miss. Just pipe up and we'll make sure you get that.
Okay, sounds good.
Yeah.
Welcome, you guys.
A year.
Sorry.
One. Oh gosh. I'm a therapist, and
Actually was born here. And then work experience. Yeah.
a girl. You get to be a boy.
A boy. Okay.
Okay. I would kind of like talk through. I imagine it will probably.
November 28th.
Okay. And what about you?
Chris, I think you're on mute still.
Yeah, I couldn't hear you guys. Sorry.
Oh, can you hear us now?
Yes.
Okay.
So Katie, tell us,
Now I can hear Jennifer. When no, it's weird. I don't know.
can you hear us now?
Yeah, if you're closer, I can hear you.
So tell us, is this your first baby? When's your due date? And who's your doctor? And who are you? And who is your labor partner? If you have one.
Okay. I'm Caitlin Wolf. My due date is November 1st. My doctor is Gallagher. We don't know if we're having a boy or a girl. My husband Sean's here with me. And was that it?
Yep.
Okay. Yep.
So
All right, we're on sale.
nutrition. Preterm. And then more about.
Hey, Megan.
Yeah.
I can't hear you guys.
I'm in the same.
Sorry to interrupt.
That's fine. Annica's gonna try to make it work on her.
Make it what?
She's gonna try to get it to work.
Okay.
So it is recommended. I think. Oh gosh.
So yeah. So we'll talk a little bit.
Sorry, that's
I could hear that audio better.
Okay, how about now, Katie?
That's much better.
Okay, perfect.
Okay. All right. So what I was just saying before, Katie, is just it's good to get your flu shot before you deliver. And I'm sure Dr. Gallagher he'll be on it. So the discomforts of pregnancy, so headache, congested nose, bleeding gums, that's all has to do with the fact that as you enter like the third trimester of your pregnancy, your blood volume is like doubled what your blood volume was before you were pregnant. And so everything is just bursting at the seams. All your vasculature is filled full of fluid, which is protective because when we have babies, we bleed a lot. So we want to be prepared for that. But one of the side effects is that everything just is swollen and congested. And that is not uncommon. Morning sickness, hopefully, are you guys feeling okay? Hopefully that's passed for the most part. You feel good? Do you feel good? Oh, that's
Nice.
great.
It worked out well.
And you feel good, Katie?
Yes, I do.
Heartburn, also not uncommon, especially as that baby is pushing on your diaphragm. And then just the prostaglandin, which is a hormone circulating in your body when you're pregnant, just makes all your smooth muscles relax. And so that diaphragm and the basically like the valves that close off your stomach from your esophagus, everything just isn't working as well as it was before you were pregnant. And so that gastric content can just go right up your esophagus. Hi there.
Hey, come on in.
And cause heartburn. And that's quite common. If it becomes like a chronic issue, sometimes your doctor will start you on a prescription for it. But if it's something that you can manage with Tums, then that's probably what you would do. Constipation for the same reason, that your smooth muscles are relaxed. So your bowels aren't working as well as they were. Swelling, and that's just due to the increase in blood volume. Varicose veins, skin changes. So you might notice like different pigmentation on your skin. Some people will notice that, and some people feel like their skin looks better when they're pregnant. Stretch marks, backache. So that's probably one of the most common complaints of pregnancy. Is anybody feeling their back?
Not anymore.
No? Feel okay?
I was really bad. Yeah, really, really bad.
So a lot of women in pregnancy will see Annika for physical therapy, and she can evaluate each patient like individually. You know, if you've had like past injuries or past diagnoses, she can kind of tailor like an exercise or a stretch program fit for you.
Because that can even, and with that, I mean, that can even play a role in labor, right? Because if you have a history of back pain, or you have back pain or pelvic pain through pregnancy, then there might be certain labor and delivery positions that don't work for you, or that could cause more of a problem. I've treated patients whose kids are 6 and 7 years old, and they still have injuries left over from birth because they had an epidural and someone cranked their leg up this way, and then X, Y, and Z happened. And so these are things that are really nice to get a hold of early, even though we kind of label them into like, well, you're pregnant, but I once had a provider tell me, well, just because you're a woman and you're pregnant doesn't mean you have to feel this way. So that's kind of the mode I take, that if it's something that we can really affect, then let's get after it.
Urinary frequency. So round ligament pain, that is the ligaments that hold up your uterus. And so I feel that most patients really have discomfort like in the lower abdominal region around close to 20 weeks. And it seems like that's when they're really stretching and starting to hold on to that uterus. So that's not an uncommon complaint. Urinary frequency, you see that poor little bladder is squished by that baby's head. And so even though you just peed 30 minutes ago, now you have to pee again. And that, you know, not uncommon. Yeast infections, not uncommon, but your doctor would want to treat that just because any infections, bladder infections, yeast infections can put you into preterm labor. So that's something that we want to manage if that seems to be a problem. Fatigue, and then pica, which is like abnormal cravings where women want to eat like dirt and laundry detergent, things like that. So we don't want you to do that. We want you to talk to your doctor about that. So normal pregnancy weight gain. If you were a normal BMI when you got pregnant, the expected weight gain is between 25 and 35 pounds. And I know for myself, when I got pregnant, I was like, oh my gosh, I'm not going to gain that much weight. And then I don't know what happens. Like you just find out you're pregnant and then you gain 35 pounds just like that. If you were underweight when you got pregnant, then we would want you to gain a little bit more weight while you're pregnant. And then if you were overweight or obese, we might expect you to gain a little less weight. I think that it's kind of hard to control how much weight you gain or don't gain during pregnancy.
I gained 45 pounds
Yeah.
both times. And a lot of it has to do with like the biggest thing we're looking for, like why you get weighted every single time you go into the doctor's office is because they want to know, number one, that it's progressing. So we should see like a pretty steady incline. And then they're also looking for any jumps in weight. So like if they say like, oh, you know, you're 150 pounds today or 160 pounds and then like in your mind, you're like, well, gosh, the last time I weighed myself a week ago, I was 145. Like that's something to mention to your doc. So that's one of the big things that we're looking for is like a really dramatic gain in weight. Although sometimes it just happens. Like you might, like, I think I had one like 2 week, I had like a 2 week visit where I'd gone like at 28 weeks and then at 30 weeks. And I think I gained like 14 pounds and it like nothing was wrong. Like I just was eating for like 14. So, you know, it happens. And then I think the next time I had lost 6. So,
Oh,
yeah.
I never lost any weight. But yeah, like I think I gained 39 pounds with all 3 kids. So it is, I mean, but it definitely varies. Like some women will gain different amounts with each baby. But it's something I guess to expect. So where does that weight gain go? So your breasts can increase 1 to 2 pounds. Babies are generally 6 to 8. Your placenta is 1 to 2 pounds. Uterus is 1 to 2. Amniotic fluid 2 to 3. And then your blood doubles in volume. So that's 3 to 4 pounds. And then protein, fat storage, and your body fluids. And I think your body fluids can affect your weight gain significantly. Like if you end up with a little bit of preeclampsia and you end up really swollen, you can pack on a lot of weight just with water weight versus if you don't. So a little bit about nutrition. I mean, when we started the class, we kind of went around the room and talked about how far along we were. So when are you due and who's your doctor?
Right now I'm seeing Dr. Can.
Okay.
That's gonna switch after my next appointment.
Okay.
I'm 33 weeks
Okay.
right now. I'll be 34 on Friday.
Do you know which provider you're going to switch to?
I believe,
Would be Foster or Hussey or Gallagher, probably. Gallagher.
yeah,
Okay.
'cause I originally was seeing Hussey, and then I went back home up to Washington for a couple months. And then when I came back down, he was completely booked up, so
Okay.
they put me in with Can. And then I believe I'm gonna get switched to Gallagher.
Okay.
What's your name?
Rachel.
Rachel. Nice to meet you.
Okay.
Megan and Annika.
Yes. So, I mean, we're far enough along in our pregnancies that, like maybe you started off your pregnancy eating really well, or sometimes in the first trimester, if you're really sick, you're just like surviving on saltine crackers and 7-Up or whatever you can keep down. But it's never too late to like really work on your nutrition and just try to make sure that you're fueling your body with the best foods that you can. But what I really like to say is, even if you maybe don't do the best between now and when you deliver, really try to think about coming in to deliver with like good fuel for your body. So I distinctly remember delivering a set of twins at like 2 a.m. and this mom was completely pooped. She had no energy to push. And the doctor said, "What did you eat today?" And she had had one cupcake for breakfast like 18 hours before and nothing else to eat, you know, while she was laboring. So think of this as like a marathon. If you were going to run a marathon, you would not probably eat a cupcake and then nothing for the next 18 hours, right? So the hospital will feed you breakfast, lunch, and dinner. So breakfast is at 8, lunch is at 1, and dinner's at 6. But we don't have a lot of snacks and we don't have a lot of availability in the middle of the night. So I would highly recommend that you pack snacks and bring them with you. And you may not, you know what I mean, like the special comes and it's like a bowl of chili and you're, you know, in the middle of labor, and eating a bowl of chili probably isn't what you feel like doing. So just like think about like what are, you know, a granola bar, a banana, or, you know, what are snacks that you can easily eat, you know, day or night, whenever you're hungry. So think about that as you're packing your bags and getting ready.
And even towards the end of labor, and even towards the end of pregnancy, you know, because you're like, we saw how the bladder was getting squished. Well, the same thing happens at the top to the stomach. So your ability to tolerate a whole lot of food, or your ability, you know, to not get reflux and like keep everything down. So small, frequent meals throughout the day. And then, you know, I kind of like this diagram because it's showing a variety, right? Like mostly vegetables, protein and some healthy starches, and a little bit of fruit. Because if you can fuel your body well now, that helps to battle some of that like fatigue that you're getting from, you know, not sleeping super well, or, you know, like having more difficulty turning over, just general energy throughout the day because you're growing a human and that's a lot of work, and hauling your body, this body that you're not used to, around all day long. So really, I mean, this fueling is in preparation for labor, but also just going into labor as healthy as possible and as fueled and fit as possible in terms of your nutrition, because that's going to prepare you a lot better to go through that marathon. So in addition to nutritional preparation, we can also think about the physical preparation. So working to make sure that the appropriate muscles of labor and delivery are fit, right? And we don't really think about that because there's a lot of components to labor, right? A lot of it just takes over on its own, which is absolutely true, but there are things that you can do to help make yourself stronger within that. So in pregnancy, benefits for women are that exercise would improve sleep and reduce stress. It's a way to expend some of that energy, especially in really uncertain times like we're dealing with now. Increasing that strength and endurance of those muscles in childbirth, decreasing back pain. So like Megan was saying, if you have back or pelvic pain, that is a fantastic reason to come see me at any point in your pregnancy. And then the other thing that I really like about exercise is that if you're working to, like, let's say baby's not in a great position, like baby's either sunny side up or breech, exercise can be one of those things that helps to get them into the position that you're looking for. And if baby is in the right position, then there are specific exercises, but even exercise in general that can help work baby, like shimmy baby down into the pelvis and really get ready for delivery. So is it safe to exercise? And I love these two pictures together because if you've ever Pinterested like fit pregnancy workouts, you always see the person on the left. I will tell you from personal experience, pregnancy feels like the penguin on the right, right? So you're like, I'd love to be the lady at CrossFit lifting 473 pounds, but instead I am just going to waddle myself right over to the fridge for my 4th snack of the day. And you know, like that's just real, right? So the answer to the question, is it safe to exercise, is yes. So if you were doing CrossFit before pregnancy and lifting 473 pounds before pregnancy, there are no adverse effects of exercise during pregnancy on infant well-being as measured by length of the baby, weight of the baby, and APGAR scores. Does everybody know what an APGAR score is? Okay, so that's, if you don't, that is the measurement of that we give a baby at
So at 1 minute and 5 minutes after birth. And so we assess their heart rate, their respiratory rate, their tone, their color, and their like grimace. And then we tally up those points, and they get either 0, 1, or 2 points in each of those categories. So the best APGAR score you can get is a 10. Dr. Gallagher says I'm a stingy nurse because I rarely give out a 9. But it's just a score of how well baby is doing at 1 minute and 5 minutes.
So what they found is that women who had exercised versus women who hadn't exercised, there was no significant difference in the APGAR scores of their baby, which means that exercise doesn't necessarily help the health of your baby in terms of APGAR scores, but it also doesn't take away from. So people who are, I've had several patients who are concerned about exercise, like I'm afraid to hurt the baby, and we think about it in early pregnancy. Sure, like doing heavy weightlifting, like lots of impact, like really like playing like volleyball or basketball where you're diving or potentially, getting hit in the abdomen. Sure, we can think about those things as being potentially detrimental. You may also not feel well enough to do those things. But I think the biggest thing is listening to your body. So if you have not exercised for a while, then even beginning with as little as 5 minutes a day, even now, is a great way to start preparing your body for labor and delivery. And then you can build yourself up to 10, 15, 20, 25, and then up to 30 minutes a day. If you have exercised before pregnancy, like we said, as long as your doc is okay with what you're doing, and I would tell them, well, I go to CrossFit and I do, jumping jacks and push-ups and all the crazy things they do at CrossFit, which keep physical therapists employed. If your doc says it's okay, then absolutely go for it. And then when people ask me about exercise recommendations, I tell them the same thing. If they're coming to me for a back pain issue, I'll suggest things to avoid or not avoid, but if it's feeling good and it's something you did beforehand, fantastic. So interestingly, the exercise recommendation for pregnant women is the same as for non-pregnant people. So it's still 150 minutes of exercise a week or 30 minutes a day, at least 5 days of the week. The problem with pregnancy is you have way more blood volume going through you. And then the ability to get dehydrated because of the additional weight that your body has not yet adapted to is a lot harder. So you want to make sure to not overheat, especially when we have these like super high fluctuations in temperature. And so you want to warm up and then either warm down or cool down when you exercise. I've had several patients though who have like ran all through pregnancy or ridden horseback all through pregnancy. So again, if it's something that you did before, chat with your doc, come chat with me, but in general, it's okay to continue doing afterwards.
Dr. Gallagher is probably like the most vocal of all of our doctors. So I will offer a lot of his advice and input as we go along because Dr. Hussey is a man of few words. He doesn't usually say too much. And Dr. Foster kind of is between the two. And Dr. Tan, she's pretty new here, so
we're not quite sure.
I don't have a great gauge on her. The time, I love working with her. She's super knowledgeable. I just don't know all of her mannerisms yet. But Dr. Gallagher will always say, like, pregnant women are not China dolls. Like, we don't need to treat them like they're about ready to break. But he'll say, if you want to ride horses, that's fine. Ride the kid's horse. Like, don't be getting bucked off. If you want to ski, great, but ski the bunny hill and be a good skier. You can't end up flopping on your belly. So it's okay to do exercise and to be active, but pick and choose your activities.
Mm-hmm. Absolutely. So here's just a sample exercise program. So 7 days a week, you could do, so this is a Monday through Sunday. So we're looking at about 5 days of cardio, and then LSD is long, slow distance. So that would be like, so maybe you're doing like an elliptical or a rowing machine or a stair climber Monday through Friday, but then Saturday you just go on a long walk. So something that's low, slow impact. Stretching is really fantastic during pregnancy. We all hear about the relaxation of the ligaments and joints and everything that happens during pregnancy, but we're talking about relaxation in terms of millimeters, which is significant. It's significant for your brain. Your brain recognizes that laxity, but we actually need a lot of that flexibility, both for delivery, but then also as your body changes, you want your muscles to be able to adapt. And stretching is a really great way to help your brain reorient to that new range of motion. Yoga, just basic stretching. If you foam roll, that's another great thing to do. And then I'm a huge fan of weightlifting. I think that's one other way that we can really like add some compression to our joints, improve the ability of our brain to know where we are in space, and then you don't wind up with the pregnant lady waddle. The pregnant lady waddle is the cause for a lot of injuries in pregnant women. So if you can avoid the pregnant lady waddle by doing some of these things, that's really fantastic.
Go ahead.
You've never seen a pregnant lady waddle? It's like when it's like belly out, and then it looks something like this.
I just saw it.
Yeah. Usually people aren't that traumatic, like most of our brains correct, but every once in a while I have a person and I'm just like, we need to stand you back up here.
Annika and I have gone through quite a transformation because when we taught this class, the October class last year, we were both, super pregnant. I didn't make it to the 4th class because I delivered. And so, but it was like, April before we delivered, July before we delivered, like we were just like, we were exercising and we were hiking and we were eating healthy and we were just like going to be the champions of like the healthiest pregnancy on the planet. And then we delivered and then we came back both with newborns, like sleep deprived, bags under our eyes.
I think we were both in
and
sweats.
that whole class was just all about like survival. Like, like you can read all the books in the world that you want, but really it's just about surviving. And so now we're like climbing out of that slump. Like now we're like, you'll survive the first year.
Barely, but you don't.
Oh gosh.
So here's just a series. So this is just some examples of a pregnant lady doing some exercises, and we are going to go through some of those. So I bet you guys did not expect to be exercising today, but we totally are going to. So go ahead and just kind of stand up and find yourself a little space, and partners too. And everybody's going to do this, right? Somebody had a role in getting you into this mess, so we all get to be involved. So really great exercises for labor are anything that work the hips. So the very first thing is just a standing partial squat. So everybody go ahead and you can hang onto a chair if you need to. You don't have to hang onto it if you don't feel like you need to, but just doing a little squat. And you can make it a teeny tiny squat, or you can make it a big deep squat all the way to the floor. Here, I'm going to stand here in the middle. You can make it a big deep squat all the way to the floor.
Is she watching you?
Oh yeah, maybe.
I'm watching. I'm just standing up, so that's why.
Okay, perfect. Well, I'll turn the computer so if you flip over the screen, you should be able to see me. Yeah, so squat, I mean, even a squat this tiny, activating those muscles is enough. The key for a squat is, this is not a squat. Those are knee bends, right? So it's butt back and knees bent. Really great to do during labor, especially in early labor. Just a great way to open up your hips. You can make it wider and go down into more of a sumo or just a normal squat. The next thing is lunges. So my personal preference is a reverse lunge. I think it's a little easier on the knees. It loads the glutes a little more. So everybody go ahead and give that a try. So in terms of labor, alternating, right? So you can go all the way down, or you can make it just little. You don't have to go all the way down, right? Right. There's a woman I watched at this YouTube of her labor, and she, early labor, she's like, and by the end she was like, oh my God, like hanging on and like barely squatting, and that's okay, right? So that's the progression, because baby's getting lower and lower. That's the point of these exercises. We shimmy baby down through your pelvis by taking those millimeters that we're getting out of each joint and shimmying down a little lower. Okay, I think that's all I have for standing. So the next we're gonna do is on hands and knees. So let me demonstrate this really quick first. You're gonna be on hands and knees. Sorry, Katie, I don't know if you can see me. You're gonna be on hands and knees. You're gonna let baby sink to the floor, and then you're gonna suck baby up towards your spine without rounding. So you're gonna stay nice and flat. Baby drops to the floor, sucks up towards your spine. All right, go ahead and give that a shot. Good, so let baby sink towards the floor. So back your butt up just a little bit. There you go. Yep, and then get your wrists underneath your shoulders. Good, and now let baby sink to the floor and then suck baby up towards your spine. Sink to the floor, suck up towards your spine. Good. This is also another nice thing while we're here. If you want to do a little cat camel, so let your back sink too, and then round. So tuck baby up towards your spine and tuck your butt underneath. Good, and then sink again and round. I loved this when I was pregnant. And this is also a great ab strengthening
If
exercise
you
too.
are a patient that wants an epidural, it may not be uncommon for the anesthetist to come in and say, round your back like a cat. And that position that Annika was just doing, can you do it again? That's exactly what they want you to do, is like rounding your back.
Why is that?
Why is that? Because it opens up all the vertebrae in your back, so your vertebrae are stacked on top of each other. So when you round, you open it up and you make more space for them to come in and insert the epidural. So we won't get off on epidurals quite yet, but I just wanted to,
It's a good skill to have.
yeah,
And
to
you
be
wanna-
able to really round your spine.
And you want to think butt and back, right? So you don't just want to arch through your back, you also want to really get your butt tucked underneath. I had a professor in PT school who said, pretend like you got, first he said $100 bill, and then he's like, no, you guys are cheap students. Pretend like you have a $20 bill stuck between your butt cheeks and somebody's trying to pull it out. That's how hard you want to squeeze your butt muscles together.
Won't lose that.
All right, so still on hands and knees. This is another one called a bird dog. It's pretty high level, but we're alternating arms and legs. The tendency that we have as pregnant people is to let our bellies sink towards the floor, but if you can hold baby up towards your spine and keep your back straight, this is a really fantastic exercise, especially if you have back pain. It also is gonna help your core, which during your contractions, that's what's helping to push baby down. While we're in this position, we've also got a plank. So everybody loves a good plank, right? So you can be up on your toes. Yep. And then if you're pregnant, you're gonna suck baby towards your spine and squeeze your butt muscles together, right? If you're like, heck no, there's no way I'm getting up on my toes, you can be on your knees and then just bring your butt forward. There you go, good. And then tuck baby up. Yep, and then tuck your butt muscles underneath. Good. Yeah, there you go, perfect, got it. If it feels easy, then you're probably doing it wrong, unfortunately, with planks. Okay, and then the next one is a side plank. I promise you guys, the hospital's like the cleanest it's ever been. So if you're worried about being on the floor, it's just like a great time to be on the floor. All right, so one elbow underneath, and really make sure to get it underneath your shoulder. And then I prefer to bend my bottom leg. So I bend my bottom leg, and then what you're gonna do is lift your hips off the ground, keeping that knee on the ground. And then if you're feeling really spunky, you can lift your top leg. Right, so these muscles right here, these are the ones that help to arrange your pelvis. So if you're feeling some pelvic pain or feel like something's kind of off, doing this exercise is a really great way to help reset that. All right, and you do that on both sides. And then the last one, nobody get up yet. Last one, last exercise is gonna be on your back. So this is called a bridge, right? So you're laying flat on your back, and this is helpful for in terms of like rolling over in bed is like the biggest help for this. But again, tuck baby in towards your spine and then push your pelvis upward. So all your effort's coming from your butt, not your back. So don't lift the baby up, tuck baby in and then lift. Good. Yep. All right, and then these next exercises I want to share, they're called the Three Sisters. So these are actually from a set of midwives. It's like northern Mexico. They had a group of midwives that delivered all these babies, and they had these amazing techniques that they now call spinning babies to get babies positioned in the right way. So the very first thing they did was called an inversion. Before I was pregnant doing this inversions, I was like, gosh, this would be great to do while you're pregnant. And then I did it while I was pregnant, and I thought my eyeballs were gonna explode. So what I like to do instead is to go butt in the air and head on the floor. Good, and so you really wanna get your butt super high in the air, so maybe back your arms up just a little bit. There you go. Yep. And then try to just let your upper back sink. So what you should feel, pregnant people, is some of that pressure coming off your pelvis. So it should give it a little bit of a release. If it feels really good and you don't think your eyeballs are gonna explode, you can put your knees up on a couch and then really get inverted. You can also do this laying on your back. That's how I've done it before. If you've got like a wedge pillow or even like an ironing board, you can lay with your head on the downside of the ironing board, laying up against a couch or something kind of short. Your head's down here and your legs are up here just to pull baby out of your pelvis and give yourself a little break. The next one is side lying. So we're gonna go back to laying on your side. This is probably best done on the edge of a bed, but the kicker, like most of us when we lay on our side, we like twist ourselves. So what you wanna do, pregnant people, is you wanna be totally on your side, and then you're going to take your top leg and let it hang over, right, like this. So when you're on the floor, you don't go anywhere, and that's fine. When you are laying on the edge of a table, that leg is gonna try to fall off. So partners, you're gonna come in at this point and hold the pelvis. So mom doesn't roll, right? Yep, so partner, yep. Yep, so partners, go ahead. So just like how Megan is right now. So if Megan was to let go, yep, I'd roll forward like that.
That's not what we're advising.
Yeah, do not, doesn't matter how upset you get, do not let her go, right? So this is amazing for any sort of pregnancy back or pelvic pain. This is an amazing stretch. Right, and then you do this both sides. So instead of doing it on the floor, do it on the couch, and you'd be right up on the edge of the couch and you just let your leg go. And so partner, you could be sitting in front or behind or whatever works. I would suggest probably in front, just so that way she feels like nice and secure, because mom, what you wanna do is totally relax into that. And then the last one is called rebozo sifting. Do you want me to sift you or do you want to sift me? All right, I'll sift Megan. So what you're gonna do, moms, is you're gonna go, moms are gonna be hands and knees. And what you're gonna use, so you guys could use this sweatshirt, that would be fantastic. And I'm sorry, you guys, I didn't bring blankets in here. I wasn't thinking far ahead enough. But what you do is you take a blanket and you're gonna put it underneath the belly, underneath her belly. So belly, like belly's on top here and your blanket is underneath here. And then bring it up both sides. And then what you're gonna do is sift and give her just a little shimmy. So you're gonna make, yep, so you can go side to side like this, and then you can also shimmy up and down like that. And so let's try it without, well, they've got their, and so if you have a sweater, go ahead and try it, but if you don't have a sweater, you can just take your hands on either side of her hips and just shimmy like this. And then, so I would shimmy this way and this way.
No, that's how the baby showed up.
Well, you're safe for another couple of months.
Yeah. Pregnancy is a great contraceptive. Right, so that's another great way too. Like if you feel like your pelvis or like low back is stuck, this is a great way to undo that. This is also really great during labor, in order like to help kind of relieve some pelvic pressure. If baby is sunny side up, so the back of their head is towards your pelvis, that's also a really great way to like pull baby away from that and try to shimmy them into the right place during labor and delivery. And before too.
I hope Sean was on the floor shimmying your hips for you.
Absolutely. Why do you think I turned the video off?
Oh gosh. Okay, so we're going to talk a little bit about birth. So birth is normal. That's why we're all in this class. We expect it, like we're preparing for it, and it is uncomfortable, but it's like a normal discomfort. Our bodies were made for this, and it's such a natural process, and it's pretty dang cool. So we're going to talk about the 4 P's of labor. So the first is the passageway, then the passenger, which of course is the baby, the powers, which would be your contractions, and then your mental state around labor. So let's start with the passageway. So let's see here. So the passageway is your birth canal. Let me find a good picture here. Here we go. Okay, so this is the uterus muscle. So I think of the uterus and the cervix as like a balloon, right? And so the ball of the balloon is your uterus, and the neck of the balloon is your cervix. And so the further that baby's head comes down, the more that it shortens your cervix, right? So it's just like blowing up a balloon. The more you blow up a balloon, the shorter the neck of that balloon comes. Somebody also explained it like a turtleneck, right? So like if you are pulling a turtleneck down over your head, the further that turtleneck gets down over your head, like it starts off with a really long neck and then it just gets shorter and shorter as that head is coming through. The same exact thing happens with your cervix. So when you come into the hospital in labor, the nurse or the doctor is going to check your cervix, right? So we're going to put on a sterile glove. We're going to go in and do a vaginal exam. And that's what we're doing, is assessing your cervix, assessing your labor, okay? So the nurse or the doctor is probably going to assess your cervix, and then they'll probably say something like, you're 3, 50% and -3. And you're like, gosh, I wonder what that means. So this is what we're talking about. So let's start with dilation. So the first number that we talk about is cervical dilation. So that is how open is that cervix. So when your cervix starts off, it's completely closed. And that's what like keeps bacteria and infection away from the baby. So it's like the uterus is completely, like that baby is completely encapsulated in that uterus and there's no bacteria getting into that baby, right? As you start to get closer to your due date, your cervix might start to dilate a little bit, and that's normal. And you might notice that your mucus plug falls out. Now, some people will notice that and some people don't. And your mucus plug is really just the mucus that has been like collecting and sitting in this cervix for the last, 37, 38 weeks. Some people will notice they pass their mucus plug, other people don't. But we have to get, so this is how we measure your cervical dilation. So this would be 1 centimeter. So that's if I go in, I can only barely get the tip of my finger in your cervix. That would be 1 centimeter. We have to get to 10 centimeters before we're ready to have that baby, right? So that cervix has got to go from completely closed to 10 centimeters open. So that's a big change that has to happen, right? So the first number that we're talking about is your cervical dilation, right? And I think in terms of like, when your crazy cousin or your sister or whatever is like texting you how their labor is progressing and they're like, I'm 3 and now I'm 4 and now I'm 5. That's what they're talking about, is your cervical dilation. That's what most people talk about, because that's how most people think that's like the only assessment of labor. But there's 2 other pieces to it. So that's the first piece. The second piece is effacement. So 50% effaced. So remember we said when the cervix starts off, it's really thick. So it's actually like 4 centimeters thick. It's quite thick. And by the time it's completely effaced or completely thinned out, it's as thin as a piece of tissue paper, like literally just a little tiny membrane, and that's all there is left of it. So when we're assessing effacement, that's how thin is your cervix, right? So if the doctor assesses you and says your cervix is still thick, that means that it hasn't started to thin out much. It's not effaced very much. But as it continues to thin out, that effacement is going to increase to 100%, okay? And that process, like that, it all kind of happens, it can happen like at the same time, right? Like maybe you're like 1 centimeter in thick, and then you start to dilate and you start to thin out at the same time, which makes sense, right? Because as that baby's head is pushing down on your cervix, not only is it pushing against your cervix, but your uterus is contracting and pulling the sides of your uterus and pulling the sides of that cervix up. So it's thinning it out and dilating at the same time, okay? And then the last part is station. So that is how far down in your pelvis is baby's head. So when we go up and we assess your cervix, we're also feeling to see how high up is baby still, okay? So 0 station is when the baby's head is level with mom's sit bones. So like the bony, I guess like the bones that you feel when you're sitting on a chair, those are your sit bones. And so when we reach up, where is, like, if baby's head is level with those bones, that's a 0 station. And then every centimeter up higher is -1, -2, -3. And then as baby is coming down, that's a +1, +2, +3, okay? And then a +5 is like a large crown. That's like a good part of baby's head is out, right? So like a -3 centimeters, like, yeah, your baby's head is right there, but this is still quite a ways to push a baby's head, right? In terms of like getting that baby delivered. So, you know, like, yes, your baby's this far away and I can feel it with my fingers, but in terms of pushing it out, we still have a little ways to go. Does that make sense? Do you guys have any questions about that? So in terms of like how we define early labor versus active labor versus transition, a kind of an older definition is 0 to 4 centimeters is early labor. And they've more recently changed it to be 0 to 6 centimeters. So in a bigger facility where they have a lot more women delivering and not as many OB beds, if you come in and you're 3 centimeters, they're probably going to send you home and they're not going to admit you to the hospital until you're like 4, 5, 6 centimeters. Here in Lakeview, we're a little bit more like generous, I guess. And we admit you generally quite a bit before that. And it also depends on like, do you live 2 blocks down the street and it's like a nice sunny day outside? Or do you live in Eagleville, California, and it's a blizzard outside, you know? So I feel like we really kind of gauge like, where do you live? What is the weather like? What do the roads look like? All those things kind of go into play. Like, is this your 7th baby or is this your 1st baby? You know, we kind of add all those things into the equation, which is nice. So that is the passageway. That's how that baby has to come down. That's how your body has to open up to allow that baby to pass through. So the second thing is the passenger. Of course, that's our baby. So as these babies start to come down, right? Like, it's not just like a straight shot. Like, they can't just fit out anyway. They have to like really shimmy themselves in order to fit through that birth canal. And there's not a whole lot of extra room, right? Like, we're talking about like millimeters of space on either side. So anything you can do as the laboring mom to like help that baby shimmy down through that birth canal is beneficial. So like, why are we always preaching like all these exercises that we just did? And why do we encourage you to get up and walk and change positions and be on the yoga ball? And it's all about like, the more that you can, like the spinning babies class, and a lot of childbirth classes are all about like, it's all about rotating your hips and it's all about moving. And why do you think that is? Most likely so that you can help that baby shimmy their way into a good position that they can fit, right? So then you can imagine if you, like, there's some women that say like, I don't want to feel anything when it comes to childbirth. Like, as soon as I show up, I want the epidural and I don't want to feel anything. So you can imagine if you get an epidural and you lay in bed just like this for the next 20 hours, like, that baby has a lot harder time finding an ideal position, right? Because they don't have anything that's turning them. Like, it's 2 stagnant objects. It just takes a lot more pressure to push that baby out, right? So even if you're like, I want an epidural, that's how this is going to go, maybe consider like waiting a little while to get your epidural, right? Like, maybe you walk and maybe you do the yoga ball and maybe you do different squats and you keep yourself moving and you're in the bathtub and you're in the shower and you're taking a walk and you're doing all these things early in labor when you can still tolerate the pain to help facilitate that baby to get into a great position. Then when you get your epidural, even though you have an epidural and you can't get out of bed, like still have the nurses like roll you side to side. We just got a big peanut ball so that we can put your leg up on this peanut ball and we roll it the other way and put your other leg up so that even if you're, you know, and we're in there rolling you like every 20 minutes, like we're constantly moving you.
And you could have your partner like taking your leg and bringing it up to your chest and back
Yeah.
down and then out and back in and playing with positions of your hips. I mean, yeah, because I mean, no shame if you were like, please God, give me the epidural, like that's fine. But have a plan because like Megan's saying, instead, then you're just looking at muscular pressure, trying to shove baby down through there. And maybe your pelvis, because your pelvis is not a solid ring. You've got a joint here. It's actually called a pseudoarthrosis. So you have a stiff joint here and a stiff joint here and a stiff joint here. And so what happens in pregnancy is we get those extra millimeters of movement, like we were talking about, your brain registers that. And so what that allows us is to be able to, because the movement isn't even necessarily side to side, it's this. So you want this side of your pelvis to twist relative to the other side. So you're looking for this type of movement because that's what helps baby's head shimmy down. The most narrow part of your pelvis is between your tailbone and your pubic symphysis. And I think, I'm not going to get this exactly right, but the average distance between your tailbone and your pubic symphysis is like 13.5 centimeters. And the average baby head size is 12.9 centimeters, right? So we're talking about like a half centimeter space to be able to get baby down through there. And there are a lot of women that experience damage to this tiny part, maybe because it was a mismatch, like they had a 12.5 centimeter gap here and baby had a 13 centimeter head, you know, whatever it is. But if you can grab even an extra millimeter out of there, it's going to make it so much easier to get baby to move through there. And like Megan's saying, there are baby moves in a way where when baby's head comes down, baby will turn to get through. If you can see, like the widest part of the pelvis is here. And so baby turns and fits so their head is lined up here. And then when baby turns finally, do you guys know why we call it crowning? Because the crown, like where you would wear a tiara or a crown, that's the smallest part of the baby's head that comes through first, right? So if you think about it, a baby comes through this way versus if baby's facing the wrong way, like a sunny side up, and trying to get their face through first, this is a much bigger space than the crown of your head, right? So your body can do it. It knows how to do it. Gaining those extra millimeters, epidural or no epidural, is key. Can you tell I feel strongly about that?
Do you guys have any questions about that?
Oh, I got this. Miss turn, bring a big truck, swerve a little bit and find a few speed bumps, we're good to go.
Yeah, a little bit of jolting. I mean, that's like why they say, like, if you go on like a bumpy car ride, and part of that is because your pelvis is jolting around and that helps baby wiggle their way down. Yeah.
Does it ever happen where I guess the baby comes out that way?
Yeah. Yep.
Yeah, it's like, I would say most commonly in women that have already had several babies, like if it was your first baby and you were trying to do a face presentation, you would most likely end up going to C-section. It's pretty uncommon that you can deliver a baby with a face presentation. Now some kids would like come out, I mean, it's still like this part of their head is coming out first and they're looking up, and we call those sunny side up kids. Because most babies come out, right? So here's mom's tailbone. Most babies they're turned sideways, and then right as their head goes to come out, they look down, right? And then they come out and we deliver the top shoulder, then we deliver the bottom shoulder, and then we pull their body on out. So I would say the majority of kids are gonna come out like this.
Mm-hmm.
Do extremities come out first?
I don't know.
Like a hand. So if it was your first baby, you probably wouldn't be able to deliver like an extremity first. If you've had, I mean, if you are already stretched out, you might be able to do that, you know, like, but certainly we've taken women to C-section, right? And the baby's hand was like up here on the top of their head. That was the Van Bell boy number 2. So there's, I mean, there are definitely babies that are in different positions like that. But I mean, delivering like an extremity like this, you quite likely will break their clavicle coming through that birth canal. So you want to,
We try to avoid it. So it happens,
Yeah.
but we try to avoid it.
so most of them are going to come out like this. Occasionally they might come out like this. That's going to be a pretty hard labor. Women that
And then again, you're looking like at this part of the head, which is a little bit bigger than this part of the head.
right. Occasionally you will have a baby that's more in an extended position where it's like more like their face is trying to come out first, and that is not very successful. But like I say, it's pretty amazing that like even if babies are in a position like this where they're sunny side up, they will flip on their own, like in labor, and sometimes even during pushing, they'll go ahead and flip on their own.
Because that is the most effective
is
way to
the
go.
best.
The way the skull bones like cross over to get
Yeah.
through is so much easier through here. Because baby's looking for the easiest way out too, right? You don't have, like, my babies tend to be particularly stubborn during labor, and that's why I've had 2 C-sections. Or not even labor. My babies tend to be particularly stubborn during pregnancy. But so you can occasionally get that to happen, but baby's looking to get out too, right? So yeah, I mean, and it's the path of least resistance.
And then powers is the next part. So that is your contractions. So it is pretty amazing. Like even if a woman has an epidural, a really great epidural where you don't feel anything, just the strength of your contraction, I mean, will get baby right there to where it's ready to deliver. Like I'm sure that if you let it go long enough, that just the contractions alone could push baby out. Generally we, you know, even if you have a great epidural, we'll have you push at the end just to help facilitate that baby out. If you don't have an epidural, most women feel like they get some relief when it's finally time to push. Like when you can finally push against that pain, you feel like you can do something with the pain. And there's like a sense of relief with that rather than just like sitting there and breathing through it. Like pushing through it actually feels better. And then your mindset, like how you're feeling about this, like what your emotional state is. I mean, I just think birth is one of the most powerful things you can do. And a lot of women will say like they feel like a badass when they get done having a baby, right? Because it's so amazing that your body just pushed, you know, that your body grew this baby and then that you birthed this baby. But certainly it is not like that for everybody. So just like your mindset and your emotions and how you feel about the whole process really does have an effect on it. So labor pain is purposeful, it's anticipated, intermittent, and normal. So I think it's different than any other pain you've probably felt in your life. Like normally if you break your arm hurts until it starts to heal. But with labor pain, it's like very intense for maybe a minute or a minute and a half, and then it's gone. And then it comes back for a minute and a half, and then it's gone. And go ahead.
Kind of be like, I guess, almost like spasms.
Yeah, kind of. So like some people will compare it to like cramps when you have diarrhea or menstrual cramps or something like that, where it's like you have a really bad cramp and then it's gone. And like, you know, for a few minutes you feel just totally fine, and then another cramp hits you and it's not fine again. But if you know that and you can like really wrap your mindset around that, I think you can, like, I have this little quote here, you can do anything for a minute. And one mom came back after she had her baby and she said, that's a lie. Sometimes you can't do it for one more minute. But if that's your mindset, if you're like, don't think about like, oh my gosh, I have a 20-hour labor ahead of me. Just think about it like, this one contraction is one contraction closer to having my baby. Like, I just have to get through this contraction and then I'll have a break and I'll deal with the next contraction when it comes, you know? If you can just have that mindset, I think that's really beneficial. I think when you get wrapped up in like, when is the baby going to be born? How much longer? Why is it taking so long? When your mindset turns to that, I think it's really hard to handle those contractions.
And I think the concept of it being purposeful too is important, because then you think about every single time there's a contraction, that's one contraction closer. Like every contraction is pushing baby down, bringing baby closer to being out. There's a gal named Ina Mae Gaskin. She was like of the original midwives in the United States, and they didn't call them contractions, they called them rushes. And so they thought about them in terms of like, it's an opening, like every contraction is an opening, which is exactly what it is in terms of dilation and effacement. Every contraction is opening your body a little bit more. So like Megan's saying, getting your mindset straight in terms of what labor is, rather than going into it fearfully or afraid of it, can make a huge difference in outcome of labor. And partners, you play a huge role in that, because one of the most helpful things that can help a woman have a successful labor that doesn't get way prolonged and wind up in a C-section is a supportive partner, like that continuous labor support. So just as important as it is, moms, for you to prepare for labor, partners, it's important for you to make sure that you're fueled and that you are rested going into a 36-hour labor potentially as well, right? I mean, so you need to be rested and prepared for it as well and ready to support.
Questions?
Have you had partners, I guess, fall out, pass out?
Yeah, right into my arms.
Hope you're strong, right?
She's real strong.
He just said, I think you're gonna have to, right? Because the mom was sitting on the bed. She was bent over getting her epidural. And so he was like hanging onto her shoulders, like supporting her on the edge of the bed. And then I was reaching around him, monitoring baby on the monitor. And then he just said, I think you're gonna have to, and I think he was trying to say like, I think you're gonna have to catch me or something like that. And he just like, whoop, here he came right into my arms. And at first I was like, grab a chair. Like I was thinking I could like lower him down into a chair. And then I was like, forget it, that's not gonna work. So I just grabbed him by his belt and we just laid him right on the ground. But he was like kind of right in the way. So we were like, just kept stepping over the top of him. And, you know, but we were in the middle of like putting the epidural in. And so it was like, oh, like he just wasn't the priority at the moment. And so we finished taking care of mom and then he came to, and, but that's a perfect, I mean, he was such a great labor support person, and mom had been laboring for, I don't know, probably like 24 hours. And he was like rubbing her back with every contraction, and she was nauseated and didn't want to eat. So he had us not bring any food into the room. So he didn't eat, he didn't drink, he didn't sleep. And then he was trying to support her. And like, that's all fine and dandy if you have the adrenaline of like pushing a child out while, you know, while you're doing all that.
Help you do that.
But like, this poor guy was whipped. And so after he passed out, I just told him like, you're not really any use to us when you're laying on the floor. So like, you need to eat and you need to sleep and you need to take care of yourself a little bit. So like, just bear that in mind. Like, if this is going to be a marathon, like, okay, that's fine. If she doesn't want any food in the room, like step out in the hallway and go eat something. You know, or if she hops in the shower and just wants to take a shower for a half an hour, like lay down and take a half an hour nap, just so that you have the energy to keep going so that you don't end up on the floor.
We had a couple come in probably a year ago, and she had been laboring pretty hard since the early morning and came in, and I think she's only like 2 or 3 centimeters dilated, but they lived, like Megan was saying, they lived like 30 minutes out of town. So we were like, okay, you know, we admitted them to the hospital, and she was really, really slow to progress. And so he, like, probably when she was still like 4, 5, 6 centimeters, like he slept, and that's okay. I mean, like at that early stage in labor, like we will wake you up if anything dramatic is happening, number one. And number two, you know, there's a long ways to go still. And so, you know, so having a backup person, and our In COVID, it's different in terms of like having labor support people. Here, you can't have as many people as you want in the room anymore, but I think we're to 2.
So 3. So while you're laboring, you can have 3 support people in the room, no kids, so nobody under 18, but you could have 3 support people. They have to be the same people. So it's not like you can have like 3 people and tag them out for 3 fresh people. Like you get 3 people, that's it. But then as soon as baby's born, it's only 1 person. So probably the labor support person, I would assume that's here tonight, is probably like the person, and they don't get to tag out with anybody. That's the only person you get until you go home.
Oh, go ahead.
Sorry, question about the labor pains, how they last like a minute each?
Yeah, so generally contractions are anywhere between 30 seconds to 2 minutes. I would say most of them are like a minute, minute and a half. Yeah. And then early in labor, they might be spaced out. They might be like 10 minutes apart. And then as you get closer to having that baby, they're going to be, you know, they might be 2 minutes apart. So you might have like a minute, minute and a half long contraction, and then you get a 30-second break, and then you have another contraction.
Do you want to like, just from TV shows like Washington, do you want to know the time between?
So that's
Great
a good question. Like, so when you're trying to gauge, like, when should we come to the hospital? It's nice to kind of know like how far apart your contractions are. So if your contractions are 10 minutes apart or 15 minutes apart, like you don't need to come to the hospital yet. Like, unfortunately, babies are not born when your contractions are 15 minutes apart. So it's fine to wait until they're closer to like 5 minutes apart. And so the way to time contractions is from the start of one to the start of the next one. So it's not like, okay, my contraction just started and now it's over and now I'll time from now until the next contraction. No, it's from the start of one to the start of the next. Yeah.
Labor pains start before or after the water breaks?
So sometimes your
either.
water won't break until like the baby is born. Some babies are delivered in an intact sack of water. So your water can break and you don't go into labor. Your water can break and it puts you into labor, or your labor can start without your water breaking. So it could be any of those situations. I would say most moms, when their water breaks, they're going to come to the hospital fairly soon after, and that's fine. Like, you don't need to like drive 90 to the hospital, right? Like, take a shower, gather up your things and mosey on in. But if your water doesn't break and you just start contracting, I would encourage you to stay home as long as you can, and, you know, like, stay in your own bed, take a shower, take a nap, take a walk, do whatever you want to do, and wait to come to the hospital until it's more intense.
And there is a clock that, you know, like kind of a general clock that starts once your water breaks, because now that you've broken that barrier between the outside world and baby, you know, if with waiting too long, there is an increased risk of infection. So like just because your water breaks and you're at like 39 and a half weeks, you're like, well, we have 5 days left, it'll be fine. Like that's not necessarily the case. So you would expect when your water breaks that things would start happening.
And typically the time frame that the doctors use is like, if your water breaks and you haven't started contracting pretty seriously within 6 hours, they're going to start like augmenting your labor with medications. And then they might choose to start antibiotics at 18 hours after your water breaks, just to prevent infection. And our goal is to have baby delivered by 24 hours after your water breaks. Now, those guidelines are like not set in stone. So we take those like on an individual patient basis, but like one of my friends, her water broke and then it was like her 3rd kid. So she decided she was tired and she needed to stay home and take a nap. So she like slept for 9 hours and then went to the hospital in the morning. And that's probably what you should not do.
One thing I was going to mention too, in terms of labor support people, we don't have doulas that are here in Lakeview, which is unfortunate. I don't think we deliver enough babies probably to support someone being a doula unless every single woman used a doula. But there are virtual doulas. Like there now, like with COVID, there has been this like burst of doulas transitioning to being online. So if that's something you're interested in, let me know, because I have a database of virtual doulas. So that would be, if you're thinking like you're not sure who else you would want as a support person, that's something to look into as well.
What is a doula?
So a doula is literally just a labor support person. So they usually have like a certain amount of hours of experience in birth and labor. So they would be really good in the virtual sense. They would be really good in like coaching your labor partner to like, okay, why don't we try this, or why don't we try that, or how about, you know, like turn on the diffuser or turn the lights down, or, you know, like helping you come up with like a rhythm or a repetitious phrase to get through it. So they're like an experienced labor support person. Not that you guys aren't experienced, but yeah, so most people aren't experienced. So these people have hundreds of hours in birth.
Well, and a couple of my friends were like fairly rigid about like, no, it's just going to be, and this was pre-COVID, but they were like, no, it's just going to be me and my husband, and that's it. That's all we're having in the room. You know, and I think they were like dreaming about this, you know, 10-hour labor where they, you know, just had a baby and had a good night's sleep and a great dinner and whatever. And that's not always the way it goes, right? So when your labor support person is like, you know, 20 hours into this and they're really tired, but you're transitioning, so you really need somebody on their A game, like their moms were like sitting in the waiting room just hoping that they would get to come back at some point. And it actually worked out great because they were like, the labor support person really wanted to go out and get something to eat. And the mom was like a fresh person to come in and feed them ice chips and rub their back and whatever. And so it's, you know, totally your personal preference and what you want, but I don't think it's a horrible idea to have like a backup person. And actually just to have a backup plan, because if your labor support person gets a cold the day that you go into labor and they spike a fever or they have a runny nose or whatever, unfortunately, they're going to screen positive for COVID at the door and they're not going to be allowed back into labor and delivery, right? So that's like, just like, you know, think about that scenario where like, oh shoot, I had this one labor support person in mind and now they have a cold that might be COVID and now
So
they can't come in.
You
So
need a
just
labor
have that
support
in
person
mind.
draft, right? So one person goes down with a runny nose, you go to number two. And that's why I actually really like this idea of a virtual doula, and not to super sell it, but just in terms of like having like a constant labor support person, like, and then to have someone to support your support person, right? To be like, hey, she's okay for a minute, why don't you go pee? Like, hey, she's okay for a minute, why don't you go grab something to drink? I think sometimes that's really nice. I had a doula that I never used for my 2 births, and in the first birth, they were there for part of it, and it was actually really helpful because she was able to explain a lot of what was going on that we didn't understand, and then give us some support. So definitely something to consider if you have a limited draft, if you have a limited team to select from, or you're just feeling really inexperienced partners and nervous about it. That's something, or moms who are feeling nervous about your partner feeling nervous, you know, whatever it is, definitely something to think about.
And it is like, our staffing is really great here. So once we have a patient that goes into labor, the nurse is assigned 1-to-1 with the patient. So it's not like your nurse is going to be like, oh, great, you're here, just call me when she's ready to push. Like, we're going to be in and out of the room constantly, like almost maybe a frustrating amount. Like, you will have no privacy the whole time you're here, but that's our job. So
I have noticed that working here.
that
Very
we're-
attentive.
In hospitals, there are some nurses that have like 3 laboring moms.
Right.
Yep.
Yeah. And it is really nice that we can be 1-to-1 with our moms. It's super nice.
So when we talk about pain, we think a lot about like, oh, you know, I have pain in my knee. So my knee is sending signals to my brain like, hey, I'm in pain. But that's not actually the way our bodies work. Our bodies are just proprioceptive. So what that means is our bodies just receive information and send it to our brain. It says, hey, here's what's happening. And without thought or without emotion or without reaction, here's what's happening, here's the intensity of it, and it sends it to our brain. So when someone talks about like having a high pain tolerance, that means that their recognition of whatever input is coming from their body into their brain, their threshold for what the brain recognizes as pain versus not pain is a higher tolerance than someone who has a low tolerance for pain. Does that make sense? Like that level of stimulus required is much higher, or that level is lower. So all of us have a threshold, right? So we all have a threshold where our brain starts to recognize that. And a lot of it can do with a concept called attenuation, which is just normalization. So for instance, like if someone starts tapping you, which when you guys have a kid and they're like, mom, 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 like at first you're like, what? And then eventually like they're tapping and it'll be like 3 minutes. And then you're like, oh, I'm sorry, did you want something? Right? So you become, so you stop paying attention to it, right? So that's that difference between, that's that attenuation concept. Like your brain normalizes to it and says, oh, actually that's not a threatening or dangerous stimulus coming in. That is just a stimulus. So when we think about pain coming into the brain, it actually, wherever that threshold is of stimulus determines how quickly it gets to your brain. So if you guys think about it, if you're, have you guys all been in a haunted house, like where you walk through like a haunted house? So you go into the haunted house, right? You know, it's going to be scary and you're like waiting for the first thing to jump out at you, right? And someone like trips and you're like, oh my God, right? And it's like someone literally just stubbed their toe. That is a predictive response from your body. So your body's already amped up. So when we're talking about having a good mindset going into labor, the same thing happens in pain. So if you are amped up and anxious and stressed and someone like pokes you in the back, or let's say a contraction starts, your threshold lowers because your brain is already like sensing danger. Like it's looking out for where the next like goblin is going to jump out at you. Right? So this is that whole idea behind like good nutrition, like as much rest as you can possibly get, and then having that good mindset going in. A higher stimulus input, so like a knife stabbing you versus like you just laying your hand down on your leg, travels up different fibers into our brain. So the neural fibers of a knife going into your leg or something like penetrating your skin is going to travel much faster to your brain than it is just a hand laying down on your skin. And that again is protective, right? So you lay your hand on the hot stove, you've already pulled your hand away and looked at it before that burning sensation even kicks in. Does all that make sense? So what your brain does is it receives this information and works to save you before it decides, oh, hey, yeah, that actually, like I now have like a 3rd-degree burn on my hand or whatever. Like you don't even feel that initially. So in terms of contractions, number one, I mean, you can't practice it, right? You don't want to practice contractions before it's time. So we think about this concept of the gate theory. So what that means is that since we can't attenuate our body to that response ahead of time, we think about shutting the gate on that fast pain sensation that's coming up. So you can do that a variety of ways. You can do that through a different sensation. So this is why a lot of women like counter pressure, right? Like you're getting that, and like Megan was saying, women like to push against the pain because now you're shutting the gate on that pain sensation coming up and replacing it with a non-painful sensation. This is why hot water sometimes feels good, because you know innately that the hot water isn't dangerous, but it shuts the gate on those painful contractions. You know it feels good when somebody rubs your back, so it shuts the gate on those painful contractions. So that's this concept, and I think it's important to know that just because the contractions are painful doesn't mean they're dangerous, right? And we already talked about that. They're productive. They're bringing you closer to your baby. So making sure that you can attenuate it in that sense, whether it's like a mantra or a repetition or breathing or whatever it is during the actual contractions, and then finding something that works for you to shut the gate. So this might mean bringing like a massage tool, like one of those little hand, like knobby massage tool things. That might be some of the counter pressure techniques we're going to talk about next class. That might be changing position, but doing things to shut the gate on that pain and decrease your body's like initial like jerky response, fear avoidance response to it is really important. Those are like
I think
pain
this
neuroscience
is why like so many women do really well in the bathtub, because we have the whirlpool jets, right? So you get in that bathtub and you have the hot water sensation, and then you have the jets bouncing around, and women will tolerate their labor really, really well in the bathtub. And then it's like we'll get them out of the bathtub to just like monitor baby for a little bit, and they just fall apart. Like, oh my God, they can't handle this labor for one more second. And they want their epidural, but if I can just hurry up and get them back in the bathtub, all of a sudden they're like managing their labor again. And so I really think it's just like allowing your body to have different sensations to like allow you to forget about that pain, to turn off, to close the gate.
And part of that is so the reason we want to not have this pain cycle is because you get this fear, tension, pain syndrome. So fear, right? Like you're coming in afraid, or you start to get afraid because you're afraid of the next contraction. Again, that increases your perception of pain. You're going to tense against it. And then you're going to like redouble your anxiety because you know it's coming again, right? And so part of what we need in labor, in the muscles of your pelvis, is relaxation. So there's so many points in this fear, tension, pain syndrome cycle that are problematic. The really cool thing about our nervous systems is you can't have your fight and flight, like this fear, tension, pain, like totally on alert, looking for the next like puma to jump out at you. You can't have that system online at the same time as like your rest and digest, sleepy, cuddly system. So anything that you can do to make this a calming, warm, safe environment is paramount, because that's going to help to break this fear, tension, pain syndrome. So think music, think smells, think lighting, think touch, right? So lots of women have essential oils. Lots of people bring in massage stuff, bring in your own pillows and blankets. Whatever you can do to help make that a safe space and make your body feel safe and enough to rest and digest and birth a baby, that's what we're looking for. Questions about that? Awesome. So that's kind of this in a nutshell, right? So you can relax and move, notice, enjoy, accept, versus the tension, holding, pain, fear. We'll talk a little bit next time about exactly the muscles of your pelvis and how to get those to relax specifically. That is a very good thing to practice beforehand. But again, like we're looking for that relaxation and acceptance of what's happening in order to let baby kind of travel their way down.
And sometimes we call this like the mother-in-law effect. Like if there is somebody in the room that you don't really want to be there, a lot of times women will hold on and they will not progress. And like, we just will wonder, like, why is their labor stalled out? And as soon as that one person, whoever that person is, as soon as they finally leave, then it's like, whoosh, like, there you go. Next thing we know, we're pushing, we're having a baby. And I think that's actually way better since we've had COVID, because visitors have been so restricted. But it's really great to have that discussion ahead of time, like who do we want in the room? Who do we not want in the room? You know, and if it's a difficult discussion for you guys at home, like the nurses are always happy to be the bad guys, and we're always happy to like make up an excuse for why somebody has to leave the room. And we'll do that. But it's just great if you guys can like have that discussion ahead of time.
That's so true. Someone that just found out that they're pregnant, they're like, we're so happy for COVID. Now I don't have to make anybody unhappy.
Right. And it's like a huge relief to parents, which is kind of sad that like, it's like become such an expectation that everybody and their dog can attend your delivery.
It's funny you say mother-in-law syndrome, because it is her mother-in-law.
It is for a lot of people, you know, it's not always the mother-in-law, but it's not uncommon that like people really hold on, and then finally when that person leaves, their labor goes a lot faster.
I was having a discussion with a patient earlier, and we were there's a video. I don't remember if watching this class or if I was just doing some research and watching. Oh, it's on a Penny Simkin video. So another very famous midwife. And she shows a video of a woman who's really focused and concentrating in like transition and late labor. And they're in like a big birthing room, which you guys will get to see our labor and delivery rooms. And so they're in this big room, and there's like maybe a couple of people in the corner like having a really quiet conversation, like you can't hear what they're saying at all. And the woman is like sitting there, and she's like breathing, and then all of a sudden a contraction starts, and she goes, "Everybody shut up!" And everyone kind of looks at each other, and they were like, I mean, nobody was saying anything. And so I was telling a patient of mine this. She's like, "Oh gosh, I don't want to be that person." And I think this is the importance of the mother-in-law effect, is that you need to be that person, right? Like you need to let that inner part of you out to get this baby through, right? Like you go to a different headspace because you might be pushing that 13 centimeter head out of a 13 centimeter vagina, right? So like there is not, it may take all of your focus and everything you've got. And so you've got to let it be free. And so be that woman that's screaming at the silent room for everybody to shut up, right? Because if that one little whisper in the corner is bothering you, that needs to stop. Because getting that baby out seriously is the most important thing. Yeah.
You take a camera
I'm going to say no, because we don't allow cameras in the delivery room.
Oh gosh.
So practicing this ahead of time, right? Talking through these things, thinking through things that you're going to want. I used to practice, like when I was pregnant, I got a lot of, this is going to be TMI, but I got a lot of zits on my back when I was pregnant. And for some reason that is extremely painful to me, but my husband loves popping them, right? This is a lot of TMI. This is a lot of information for you guys. I would literally practice breathing through that, like my labor breathing, like that was my cognitive rehearsal, right? Let it be that, like use any opportunity you got to practice this, like separating yourself from the pain, attenuating yourself to those symptoms. Whatever you can do to get your mind prepared and in that right space is going to be great. Breathing is so important. We'll talk more next week about, like I said, how to relax those muscles of the pelvic floor, but breathing is important. Decreased oxygen leads to increased perception of pain. So if you lose control of your breath and start hyperventilating and breathing only with the top part of your lungs, you're not going to oxygenate your body as well. That also means that baby doesn't get as much oxygenation. And so then baby stats start to decline. So breathing is vitally important for pain perception for baby, and it even helps to relax your pelvic floor. Our diaphragm, which sits on the bottom of our lungs, is intricately connected to the pelvic floor, and that's what has to relax to push baby through. Because those muscles, when we talk about women fighting it, those muscles are what tighten, and you need all of those to relax to the max to be able to get baby through, and breathing is a huge part of that. Let's give it a try really quick, exactly how we're looking for people to breathe. So everybody go ahead and put a hand on your chest and a hand on your belly, and take a deep breath in. All right, so how many of you felt your back arch and your chest lift up as you were breathing, right? So you don't have to raise your hand, but what we're looking for is we're looking for belly to expand first. So, and I don't want you to push your belly out and then breathe in, but I want you to be like a glass of water. So it's like you're pouring the air in and fill at the bottom first. So let's try it again. Take a breath in and fill at the bottom first. So what you should feel is your belly start to expand and then your chest lifts. So this is the best way to use your lungs most efficiently. This is how you can get air all the way through all of your lungs and be better oxygenated. This is also the best way to get your pelvic floor to relax, is to become very good at this breathing. So if you've ever heard of diaphragmatic breathing or yoga breathing, this is the type of breath we're talking about. So really fantastic thing to practice. There's lots of videos online. If you are like, I cannot get it, great reason to come see me, and I can teach you how to diaphragmatic breathe and get your pelvic floor to relax along with it.
I think it is like great when you do practice that breathing where you really feel your belly filling up first. Once you've done it for a while, you notice that at the same time your pelvic floor is relaxing and you can start to feel that. And probably like the most important thing is, I mean, like this slow, deep breathing is wonderful. But in like like while you're back in labor and delivery, like, don't get caught up too much on the technicalities of breathing. Just make sure that you are breathing for baby, because it's not uncommon that like a contraction starts and women just tense up and just don't breathe. They just hold their breath. And that's exactly what you don't want to do for baby, right? Like, because the only way that baby is getting oxygenated is if you're breathing for them. So the nurses, the doctors, we're all going to be coaching you to breathe. And that's, and sometimes for these poor women that have these high risk deliveries, that it ends up being like some unforeseen circumstance and they end up getting flown out, or they have an emergency C-section or whatever. Unfortunately, in that situation, like, you're fairly helpless, like you can't do much and the situation feels pretty out of control. But the one thing that you can do is breathe for your baby, right? And so just really like keep that in mind and focus on that. Like, all right, the one thing that I can do for this baby right now is breathe for them.
It's also extremely calming for you, right? Like when stress happens in our body, like if you have a really high emergent situation, you know, your body's going to tense. You're going to send off like a hormonal cascade of increasing that danger, right? So you're gonna go all mama bear looking for the danger that's nearby, and breathing will really help to reduce that as well. Because again, like, you are so intricately connected with your baby that if you kind of cycle into this stress reaction, babies do the same thing, right? Like, they're getting that series of hormones, those stress hormones. So being able to balance that with breath, like Megan said, that's what you can do. That's what you can control in that situation. And that's how you can get your body to relax. So we already talked about this a little bit. I would say, you know, as a labor coach, you know, your role is really there to support mom. So whether she needs encouragement or praise, whether she needs needs you to talk to her, whether she needs you to be quiet, whether she needs you to quiet everybody else in the room, any sort of comfort measure she might need, really as the advocate for mom, right? Like, when she can't advocate for herself, you know, and keeping her preferences in the front. And then we already kind of talked about, you know, how to choose that labor support person, and their importance.
So just a little bit about false labor versus true labor. So false labor, your contractions are irregular, unpredictable, occurring, for example, in intervals of 10 minutes, then 6, then 2. Is anybody contracting? Nobody? No, Katie? So, I mean, it kind of happens different for everybody. With first-time moms, typically you won't start contracting until later in your pregnancy. But your false labor is not going to get, the big thing we're looking for is stronger, longer, and more painful. So if those contractions aren't getting closer together, if they're not getting stronger, if they're not getting more painful, then that is an indication that this is false labor. No progression is seen over time. Usually no bloody show, and your membranes aren't going to rupture. So signs of true labor, the opposite. Contractions are regular and follow a predictable pattern. They become closer, longer, and stronger. Now, I don't think this is necessarily true that they start in your back and then radiate around to your front, low in the groin, because some women will feel all their contractions in their back. Some will feel them all in their belly. So I think that just depends on the patient. And then change in activity will not slow down or stop contractions. So it's not uncommon that if you're up, you know, raking leaves, running around the house, doing all the chores, that you might start contracting. But if you drink a couple glasses of water, you lay down on the couch and you rest, your contractions will stop. That's just false labor. True labor is not going to stop with a change in your activity, right? You could be raking leaves and your contractions could start, and you go lay on the couch and they just keep getting stronger and stronger. That's going to be true labor. And then your membranes may rupture. So one of the important things that we should talk about tonight is preterm labor. So any labor that begins before the 37th week of pregnancy is considered preterm labor. And if that happened, we would try to stop your labor. We would try to stall it until you're at least greater than 37 weeks. So if you go home tonight and you start contracting, you should not wait at home to see if this labor progresses. If it gets stronger, you should just come back into the hospital, right? Once you're 37 weeks and you start contracting, then it would be absolutely fine to stay at home, wait for those contractions to get stronger, for them to get really regular, because at that point we're going to go ahead and deliver the baby, right? But if it happens tonight, you want to come right in. So risk factors for preterm labor or birth, if you're pregnant with multiples, previous abortions, uterine abnormalities, current infections, bleeding during pregnancy, obese or underweight, poor nutrition, advanced maternal age or less than 16 years old, use of reproductive technology like IVF, smoking or drug abuse, disease in the baby or birth defects, constant emotional stress, high degree of physical stress. But it certainly can happen to any of us at any time that we go into labor. And so if you do, you would want to come right in. Now, my one plug, I mean, neither of us work for Mercy Flight or Airlink or anything like that. But when you live out here in the boonies, I would most definitely invest in flight insurance. So if you, pregnant moms and babies, we typically fly to Medford and they fly via Mercy Flight. And so like hospital employees have an Airlink membership as part of our employment benefits, I guess. But most of our moms and babies do not fly via Airlink. So you would want both kinds of insurance, or, you know, if you don't have either one, I would choose Mercy Flight if I had to choose one. And I think it's like $85 maybe for a family.
One's 85, yeah.
I think
It's
it was
like for a family for the entire year, it's like 85.
What did you say, Katie?
I think it was 70 for yourself and 85 for your family. Yeah, something like that.
Yeah, it's not a crazy amount of money. And if you get flown out of here, or if your baby gets flown out of here, you'll be glad that you had it.
That was my experience. We kind of alluded to that earlier. I came into the hospital with severe preeclampsia at 33 weeks. And so I was flown, I didn't live here at the time, I was just visiting family. And so I was flown back to Salem where we lived. And that was in a fixed wing plane. And again, we don't normally fly to Salem, but it was a $65,000 flight. So like, I remember sitting in the room, cause they had, you know, I'd gone in several times with high blood pressure and they said, oh no, you're fine. Oh no, you're fine. So I thought that, okay, I'm going to be fine. So I'm telling Terry, one of our nurses, I'm like, Terry, do I really need to fly? Like, come on, really? She's like, yes, you need to fly. And I was like, well, how much are we talking? 5,000? She's like, you don't need to worry about it. I was like, 10,000? She's like, no, seriously, you don't need to worry about it. No, $65,000. So, and not all health insurances have air ambulance coverage. So just, yeah, it's important, right? And you need it. I needed to go to a higher level of care. It was far too early to deliver here. So.
Yeah, and it happens.
Yep.
Yeah.
Mercy Flight and Airlink. Yeah, I would just get an Airlink. I would just get both because sometimes you don't always get to choose who comes in either.
Yeah, like the scenario that has happened most times is that people had Airlink and they needed Mercy Flight. Like Mercy Flight is where most of our moms and our babies go. So if you had to choose one, I would choose Mercy Flight. But if you have the resources to choose two, that's great. No, go ahead.
Question, like, yeah, her and baby have to travel, would I need to actually have that also to travel?
So this is the way it generally goes. So if you are pregnant, like let's say you're preeclamptic, like Annika was, right? And so we need to get you to a higher level of care to deliver baby. They would fly just mom, let's say to Medford, and then she would deliver there. And then mom and baby, you know, mom would be in the labor and delivery and baby would be in the NICU. And then you would have to drive over. And they're like, so Medford isn't set up to like room in with baby. So while baby is in the NICU, you would either have to have a motel or stay in like this special care, or like the Ronald McDonald House, which is like I don't know
It's
what
like
I want
for
to say.
family, like not
Yeah, it's like family living for, I don't know.
It's like
one of my
it's like a charity house, but
yeah,
it's not
one
like
of
a
my
charity.
friends said it was like a homeless shelter. But if you, let's say you were like 37 weeks, you came in, you delivered baby here, but for whatever reason, baby wasn't doing well, we would fly baby to Medford, and then you,
mom and dad,
would probably have to drive to Medford. Occasionally, now absolutely, like, do not say Megan promised me that we could fly with our baby, because that is 100% not a promise. But sometimes they will let like one parent fly with the baby. It's typically not the mom though, because if you just delivered, they don't consider you a stable patient. And so they can't have like 2 patients essentially on the helicopter or the plane. So it's just like, I mean, nobody wants to think about these scenarios, because nobody wants to think about like, oh my gosh, what if we get flown out? What if mom and baby get separated? You know, nobody wants to think about those scenarios, but I will tell you that it's not uncommon that it happens. And like families that have at least had a discussion about it handle it significantly better than families that were just like, no, that's never going to happen to us. I delivered one family and they had their first child was flown out. And so then when they had their second one, they didn't anticipate that baby being flown out, but they had everything in line. Like they were like, if we make these phone calls, this person's taking care of the dog, this person's taking care of the baby, this person is running home to pack us a bag, this person is, you know what I mean? Like they had everything lined up. They had a plan for all of this. And so the baby was like actually 2 days old and we thought it was fine. And then all of a sudden it had a change in condition and we did end up flying it out. And like, that was an unfortunate situation, but they literally just made 3 phone calls and went. And it was like not that traumatic. And so I thought, gosh, that should be a lesson to us all. Like, just at least have a conversation about it. Like, how are we going to handle it? Like, how are we going to do that? Because I think it eases the anxiety in the moment considerably.
And the odds are that, you know, the odds are in your favor, right? The odds are in your favor to not have an experience like mine where something like that happens dramatically. You know, you can read all the statistics and the likelihood is that you're going to deliver as a first-time mom. This is the thing that's always interesting to me is only 25% of moms deliver by your due date. So you will probably be past 40 weeks and still waiting to deliver. But that's the likelihood, and it'll be a healthy delivery, right? It's going to be great. But you know, that's why we have insurance. We have insurance just in case the worst happens, or just in case something very dramatic happens. And I will tell you that had we had the air ambulance insurance when we had my son, it would have really, if you buy it and you never use it, it will still be cheaper than having to pay for an air ambulance once. So I totally recommend it.
They don't pay us to say that.
Nope. They should pay us to say it.
Annika's son got flown out. My sister got flown out. I've had several friends that have been flown out. Like it happens. So preterm labor continued, possible signs 4 or more contractions per hour, low dull backaches. So some women won't feel contractions. It's just like, oh my gosh, like all of a sudden my back is just killing me. Like pay attention to that. Menstrual like cramps, intestinal cramps, or diarrhea. So this is kind of the funny thing with preterm labor. Sometimes people will go into labor and like go into preterm labor and then they'll get the symptoms like flu-like symptoms like vomiting and diarrhea. Like the contractions cause the vomiting and diarrhea. And sometimes it's the opposite way. Like sometimes you'll get the GI bug and the vomiting and the diarrhea will put you into labor. So just like pay attention to that. And sometimes that can be like an easy fix. Like you come into the ER, we give you a bunch of IV fluids, we hydrate you, your contractions stop, we send you home. So don't like stay at home and like wait to see what happens. Like I would come in if you're less than 37 weeks. And then what to do, we already talked about this, stop what you're doing, go to the bathroom, drink water, and lie down and see if your contractions get better. If they don't, I would call your doctor or go into the ER if it's, you know, like weekends or nights. So this happened to one of our patients. You're 32 weeks pregnant and you go to town shopping for the day in Klamath. You're having lunch with your mom and your water suddenly breaks in the restaurant. Your partner's at home working. What would you do? How would you cope until your partner was able to join you? How would you feel about having a preterm baby? And how would your family cope with a baby in the NICU 3 hours from home? Any thoughts?
So having had a NICU experience, it's really scary and it's really it's traumatic, especially as a first-time mom having a baby in the NICU. It's not like the births you see on TV where baby is born and they set them on your chest. Baby is born and they whisk them away. I didn't even see my son until he was probably 5 or 6 hours old. And my husband left with him. So then I was there on the operating table, like with a bunch of people I didn't know. It's traumatic and it's scary. And so, God forbid that happens to any one of you. But like Megan's saying, we had a doc here, and he would always tell Megan, labor and like having a baby, pregnancy and labor and delivery is one of the most dangerous things a woman will probably ever do in her life, and consistently do. And so it's, it is scary. And I think it's hard to get your mind wrapped around until you've been through it once. And even if it goes really, really well, you realize how lucky you were that it went really well, right? Because then now you start to hear all these stories. And I don't think it's necessarily helpful to hear horror stories like mine about like how things can go so incredibly wrong. But I know that medicine is really amazing too, right? So even though it's, like in my case, like I had a 4-pound baby, a 4.5-pound baby who dropped to under 4 pounds, the day after he was born, and babies are very resilient and they're really amazing. And doctors and nurses who work in NICUs are really, really incredible. So even if you were to have a preterm labor or a baby in the NICU, the world's going to stop for you for a little while, and that's okay. I remember it felt so crazy to me to like see people driving to work. Like, what are you doing? Like we're here and we're spending 12 hours a day in the NICU with my son. And that's really what it is. So if you do wind up in the NICU, or if your baby does wind up in the NICU, you're going to be in Medford for a while. And there are qualifications that your baby has to do to be able to get out of the NICU. So, it's easy to not hesitate for a second and just be there, right? Like, it's not even a question of who's going to go home and do the laundry. Like, well, it's not me, I'm staying here. And dads, that might be the same way for you too. And that's okay. So I think that's what taught me to let a community surround me after having a baby in the NICU, because we needed people to take care of us. So.
And certainly it's a scenario that happens, but hopefully for all of you guys, you deliver a term baby and you go home the next day, but it's great to have somebody that's had that experience so that you kind of like know what to expect a little bit,
Well, like Annika was saying, like all the professionals that work in the NICU, like they specialize with working with preterm babies.
Right. It's incredible.
They're amazing.
Yeah.
I've worked in the NICU, and it's amazing.
Yeah.
Yep. Yeah. It's incredible. I remember the first time I held my son, he is like the size of like my coffee mug, like he is not very big. And the nurse just comes in and she's like, oh, okay, we're going to flip him over and we're going to get him dressed in a little outfit and put it back. And I was like, oh my God. And she was like, okay, you need to hold him. And I was like, I'm not ready. And she's like, nope, you're going to hold him. That's what you're going to do. And you're going to change his diaper and you're going to feed him and you're going to do all these things. And so they're incredible. They're really incredible. We did have one nurse Sally. She wouldn't let us do anything because we didn't like Nurse Sally. But
There's one of those in every group.
There's a Nurse Sally.
A nurse that you don't like in every group. On that note, gosh, now you should take a deep breath and relax after we just gave you a little horror story about the NICU. But really, truly, like there's lots of videos online that you can watch that kind of just like walk you through like progressive relaxation, like anything that you do, like whether you do yoga or you just breathe or you take a walk or whatever you do, like practice relaxing so that you can do it like almost on demand, because like I work at the hospital, I come here all the time. And it's not stressful to me to come to work, but as soon as I walk through those doors, like to have a baby, even though I work with all these people, like I trained half these nurses, I know them all. As soon as you walk in the door to have your own baby, it's still like you're still anxious, right? Because it's your baby and it's like, it's different. And of course it's going to be different for you guys, maybe not you, Liz, but it's different for you guys because you don't work here every day and you're not familiar with all these people. So just, you know, just like practice relaxing so that when you get back into that labor room and you know that you're super anxious and that you're, you know, just about ready to crawl out of your skin, like know that there's something that you can do to help yourself relax. And I think once you get back there, it's easier to relax. And I tell people, like, make your labor room your nest, like build your nest. So whatever you need in your labor room to feel comfortable, like bring that with you. So if that's going to be music, if that's going to be a pillow, if that's going to be, you know, comfy clothes, if that's slippers, if that's essential oils, like whatever that is, that's going to make your labor room feel like your nest, feel like your comfortable place to be, like bring that with you so that you can relax, because there's no denying that you're going to be anxious the day that you walk in those doors to have your baby, but your labor is going to go smoother and you're going to handle it better if you can relax. So just think about that. Like what do I need to help me relax? Like, what do I want?
And there's some really great books so we don't talk about specific labor methods here in this class, but there's some really good books like Mindful Birthing, Hypnobirthing, and all of them are based in this mindset. And I'll say too, that even if you wind up in a C-section, for me, like I did both times, I still used those techniques, like especially the first one I was like ignorant and unaware of what I could have done to like make that a less traumatic experience. But I would say if you can practice some of these mindfulness techniques, even if the crap does hit the fan and things start moving rapidly and interventions are needed, those techniques are incredible. My second delivery was another high risk delivery that we did here. And I used, it was so much of a different experience, even though we were still concerned that we were going to have to fly my daughter out. It was such a different experience using those techniques. So I would say if you can, whether it's a book or if you already have some sort of mindfulness meditation that you like to use, but Mindful Birthing is one that I read that I really enjoyed personally. Another friend of mine really enjoyed Hypnobirthing, and it's all in the same basis. And there's another one that'll come to me in a minute. Lamaze is kind of the same thing. Like it's all based in mindfulness and preparation.
All right, guys. Any questions? Yeah.
You were talking about the tub. Is
Yeah.
that something that the patient has to ask for, or is that kind of?
So we'll go tour the birthing rooms next time, but there is a whirlpool tub in 201 and 202. And so, you can get up and get in it anytime you want, as long as you don't have an epidural. And then if you're a Cytotec induction, you have to stay in bed for an hour after each Cytotec is placed. But, like you can spend hours upon hours in the bathtub. Yeah.
Is that just for sitting in the tub, or do you guys offer water birth?
So we don't offer a water birth. But you can stay in the tub right up until, Annika popped in when I had my daughter. I was in the bathtub. She popped in. I don't know what she said to me. And then,
As long as you don't have enough girl.
yeah.
Okay.
And then I don't know how much longer until I had my daughter.
10 minutes.
Like, it wasn't that long.
I came back like an hour and a half later thinking like, we'll talk about some positioning, and she was like holding baby.
So you can stay in the bathtub up until the last minute. But like, then when I tell you to get out of the bathtub, you have to listen. You have to get out of the bathtub because we're not going to catch the baby in the bathtub.
Is there like a time prior to like getting the epidural though, or like the birth actually happens? Is there a lot of enough time to get that?
Oh, like when do you need to get your epidural by?
Yeah, so our CRNAs are really great. Katie, I don't know if you can hear the question. The question was like, is there like a certain time that you have to have your epidural by, like before the baby is born? And so I feel like, I don't know, like probably if you just like Googled this on the internet, they would say like, oh, you must have your epidural before you're 7 centimeters. Otherwise you're not getting it. And that is like not true, especially not here. Our CRNAs are wonderful. to work with. And so, I mean, we've started epidurals on women that are like as soon as we got their epidural in, they were ready to push and we'd had a baby. So they're, you know, and if they know that you're 9 centimeters and almost ready to push, they might just like give you like one dose and not set up a pump. They'll just give you like an epidural dose of medication, just enough to get you through the actual birth of the baby. But it doesn't have to be like, I feel like, I don't know, Hollywood makes it seem like if you reach a certain threshold, you're out of luck. You're not getting that epidural. And that's like, unless the baby's head is like halfway out, then that's a little late. But aside from that, like, we'll give you an epidural right up until the end. I do tell women when they come in, like, you know, I just say this to everybody, if you want an epidural at some point, you should probably expect like 45 minutes from the time you say, I want an epidural until you have pain relief. Because if you say, I want an epidural, I have to make sure you have an IV started. I have to give you IV fluids. I got to call in the anesthetist, and then they have to come in. They go through a tiny bit of paperwork with you and then set you up on the side of the bed and put in your epidural. And so it takes a little bit of time. So you can't say like, I want my epidural and you have it 3 minutes later. Like, it doesn't work quite like that.
And I would say too, you know, if your goal is to go without an epidural, partners, this is a great time for you to make sure that, because a lot of times women will lose control, and that'll be over breathing or whatever rhythm they had, and they'll feel like they can't get in front of it again. And so that's a really good time for you to help like reground them, and help bring them back to like, okay, like help them find a position that works. Because usually when you think it's the hardest and you can't do it anymore, it's also almost over. So just kind of have that in mind too. If you really have a goal, you know, number one, getting an epidural is not giving up. Getting an epidural is not the easy way out, because sometimes your body needs a break and you need to relax to get that baby out for both you and baby. But also know that, you know, you might be really, really close too. And so if that's your goal, you just have to help get some help recentering and keep going.
So I guess you guys are mentioning like people stay in the whirlpool or whatever for like 48 hours prior to birth. Like, how early do people usually come in prior to giving birth?
So I did the QI for our hospital in 2019, and the length of labor was anywhere between 3 minutes and 60 hours and 50 minutes. So, I mean, nobody really wants to be the mom that was here for 3 minutes before she gave labor, but nobody also wants to be the mom that was here for 60 hours and 50 minutes before she gave labor, gave birth. So, you know, I would say for first time moms, like, you're probably looking at like 36 hours. Like, it's a marathon. I don't know, maybe it's gonna be 3 minutes and maybe it's gonna be 60 hours, but, you know what I mean? But like, from the time that your contractions start, or from the time that your water breaks, like, look at this, like, I mean, kind of have the mindset, like, this could be like a day or two, you know, like, have that mindset. Like, so when you pack your clothes to come in here, you know, you like pack a little bag to go to the hospital or whatever, like, keep in mind that like, oh, like, what if I'm in labor for 36 hours? Like, I might want to change my sweatpants one time while I'm there, you know, like, just think about that.
So, I don't know, have you all seen the movies and everything? It's like, oh, my water broke, and they're like rushing to the hospital.
Right.
So I don't know if I'm gonna be like sitting at work or something and get the call like, oh, water broke.
And the baby's here already.
You missed it. The likelihood is you're gonna have time, but
Yeah.
the vast likelihood is you're gonna have time.
Yeah.
So is that pretty much just paying attention to your contractions at that point?
So like after your water breaks?
Yeah.
Yeah. So if your water breaks, you know, like, I mean, you don't need to get in like a race to get here to the hospital. You know, you have time, like, pack your bag, take a shower, gather up your stuff, you know, but like, you're going to head into town if your water breaks. If your water doesn't break, but you just start contracting, I would just like pay attention to like, how close together are they? Like, are they 10 minutes apart? Like, we could probably stay at home for a while. And I would say most first time moms don't come to the hospital like too late. They come you know, because you don't know, like you're at home. I remember with my first kid, I was like at home in the bathtub and I was like, well, I don't know, maybe I just have like a great tolerance to pain. Like, what if I'm ready to push in 5 minutes? Like, I don't know how
Look
bad.
at me killing
like,
it right now.
I don't like, you know, I don't know how bad this is gonna get. And so after a while, I think like curiosity kills the cat. Like pretty soon you're just like, well, we better go to town, because what if I'm ready to have this baby, you know? And you get here and you're like, oh, I'm 1.5 centimeters. Like, what do you do? Like, you know? And so that might be like when you have that discussion with your provider, like, is it a beautiful day and you live 3 blocks away? Like maybe you go home for a while. Or maybe like it's a blizzard outside and you live 70 miles away and you're like, okay, like let's get a motel for the night, you know, so that we're in town in case something happens, but I'm not paying, you know, $6,000 a night for a hospital bed. You know, I don't think it's really that much, but you know what I mean? Or you might say like, no, even if I was at the motel, I would still be nervous about like, well, maybe I'm about ready to have the baby. Like I would just be more comfortable in the hospital. I think the providers are really open to that discussion. You know, but if you're 39 weeks and you're like 1 centimeter and we watch you for 24 hours and you're still 1 centimeter and your water hasn't broke, then we're probably going to say like, why don't we send you on home? Because nothing seems to be happening.
I wouldn't feel foolish. Like, don't let yourself feel foolish if you come in and you're, you know, like Megan was like wondering like, well, am I or am I not? Like, how far along are we? Because, you know, we'll be like, well, you know, you're 1.5 centimeters. So, you know, there's no harm in getting checked. Like, you can always come in and get checked out.
I guess, can you have the basement be like towards, I guess, the end stage of
Yeah.
70%
Uh-huh.
but not be dilated then?
So yeah, you can be more thinned out. Like some women will be more effaced, but you have to at least be a little bit dilated for us to check effacement, right? Because I have to be able to get my finger through your cervix to be able to tell how thin it is. So yes, like you might be effacing, you might be thinning out, but maybe your cervix hasn't started to dilate too much yet.
So the effacement, like, I guess if it gets to 100%, that's when your water breaks? Or no?
Nope.
Again,
So
'cause
it's
some women
very,
will have babies born in the amniotic sac.
yeah. So the effacement is just like another part of your cervix of your like body getting ready to have that baby, but it all has to happen. You're not ready to have the baby until all the pieces are ready, right? Like you have to be fully dilated, fully effaced, and that baby's got to be like, you know, way down in your pelvis before the baby's going to be born. So it's not like you can be 100% effaced and only 2 centimeters dilated. It's still not going to happen lickety split. I mean, I wish it did. I mean, I wish you could just have these babies fast, but
Oh,
right.
Actually,
Yeah.
that's not good either. I had a patient who had her 4th baby and she basically sneezed and had a baby. And at first when she told me that, I was like, she's like, well, the baby just like fell out. And I was like, that's not how it works. And she goes, no, I went, they like had me stay at the hospital because this has happened before. And then they were like decided to do a C-section and they left. And then I had the baby. Like my husband caught the baby. And I was like, and so this woman, but what happened is the baby came out with the sneeze, as did everything else. Right. So like everything, like, I don't know if you guys have ever seen like cows prolapse their uterus, but like it all just like turns inside out and they have to shove it all back up in there. So that's not good for one's health. So be like the slow, the moderately paced, like generally painful. Yeah. Yeah. Yep. No, you didn't.
Well,
she was not
and
pleased.
we just had a gal, I just delivered a gal the other night with Dr. Gallagher and she was like, I kind of feel a little nauseous. Like maybe you should give me something for that. And both Dr. Gallagher and I were like, I mean, we can, but it's really not going to help because a lot of times just as you are getting that sensation to push and as that baby is low enough, like you just start vomiting. That's just what happens. And Dr. Gallagher reassured her that like vomiting is really effective for having babies, like probably just as is sneezing, like as you start vomiting and you increase that intra-abdominal pressure, like, oh, you throw up and you start pushing a baby out. And so we decided to not give her anything for her nausea, and we would just go ahead and let her vomit that baby out. And so that's the way it goes.
There's teamwork going on there.
Great question.
Oh, gosh. Okay, so that's it for tonight, and then we'll do it again next Tuesday. Okay? Don't anybody get scared.
Yeah. And with questions,
Too late now.
if you guys want to be, I email out to folks who are doing it on virtually. So if you guys want to be on that email list, just leave me your email here because I'll send out digital copies of all of the handouts. So Katie, you'll get copies of all the handouts from today. But yeah, so if you want to have an email list and be able to have these things digitally, just come give me your email before you take off.
Yeah,
You
you can
can
take
keep
them. Yeah. There's like a
All right,
little
thanks, Katie.
code in
Thank
them
you.
if you
I
log
might
on to the
come to some of the live classes too once, soon. So,
Absolutely. Whatever works for you is great.
I
Okay,
hope Sean
guys-
is still awake, paying attention.
he's asleep now.
Long gone to bed.
30. That's like a half an hour past his bedtime.
Yeah,
Yep, absolutely.
well,
Yeah, you
we
guys are welcome.
understand.
Only during weaning.
Only during weaning
Weaning.
and
And-
branding and going to Sycan. He's not living in Sycan?
No, he's getting up at 2 a.m. to go up there with everyone else. So, you know,
He's making the sacrifice.
can't see so last
See you guys. Have a good night.
Okay, well, holler if anything happens.
I will. I don't think it
Okay.
will yet, but you never
We'll
know.
see. You never know.
Angela might be tonight.
Oh, really?
Hmm.
Is she up in Bend or Portland?
Yeah, she went and got an ultrasound yesterday, and then today her doctor looked at it, and her cord was too long. And then with the placenta previa, and then she has it where the cord's attached to the side of the placenta.
Yeah. Uh-huh.
So they were afraid of a prolapse cord, and she
Oh.
hasn't messaged me back in a while. So I don't know.
So were they going to take her to C-section or what?
We got her admitted today, and they were going to just kind of wait it out and see what happens. And
Oh.
she might go on bed rest for a couple weeks, and she might have it. If it changes, she might have it in the next couple days.
Is she
So-
in Portland?
No, she's in Bend.
Oh, she is in Bend. Is John up there with her, I guess?
Yeah, he is. He left today.
Is she
So.
30? How many weeks?
35.
35. Well, that's not too early.
No, they
That's all
gave her
right.
a steroid shot today, I think, and
Yeah.
just gonna wait and see what
Yeah.
happened. But she could
Well.
possibly have it. So
Right.
yeah.
Okay. Have a good night.
All right, you too. Drive safe.
Okay, bye.
Bye.